Hi, everybody. Just going to give our speakers a second to come into the main stage from our backstage and let everybody get a chance to log in. And we'll go through some housekeeping items, and then we'll go ahead and get started with our webinar. And we'll just wait for Ronja to log in. While we're waiting for her to log in, I'll go ahead and just get started with our housekeeping item. So my name is Brooke. I'm a speech pathologist here with Tim's Medical, and I am really excited to have Dr. Landera and Ronja with us this evening to provide their expertise on starting and implementing a hybrid fees program. I think this offering is going to be highly beneficial for so many of us in the field. A couple of housekeeping items before we dive into content. This webinar is eligible for 0.1 ASHA CEUs or 1 PDH. If you would like ASHA CEUs for this presentation, a brief survey is required. I will put that survey in the chat. It would also be sent out via email from Zoom twice after the end of this webinar, and you'll have 7 days to complete the survey. If you would like PDHs, you don't need to complete the survey, and then if you would like a certificate of completion, just send us an email at tims-unum@tims.com. I'll put all that in the chat. And just a note that I do practice clinically, so sometimes it takes me about a week or so to get back to you on responses for certificates. With that being said, I'm going to hand over the floor to Mario.
All right. Hi, everyone. I think we got the slides on. Happy World Voice Day for those of you watching this live. I'm so excited to be here. I'm Mario Landera, a associate professor and chief of speech pathology at the University of Miami in the Department of Otolaryngology, and I've been a speech language pathologist for almost 20 years, and I'm happy to be doing this webinar with wonderful a colleague of mine, Ronja Hildebrand, who's going to be presenting the second half. I want to say thank you to all of you. Thank you to Tim's University and Brooke for the invitation to speak. And our topic is the best of both scopes, developing a hybrid fees program. These are our disclosures. We do get paid at the University of Miami, and we're receiving a small honorarium for this presentation. We're going to be going over some of these are the 4 learning objectives for this presentation. And before we start, I think it's important to provide some story time, and that's myself on the right, and that's Rania, who are going to be talking about a little bit about how this program started. So with that, first I want to show our University of Miami Medical Campus. This is a map, and this is we're located close to downtown Miami. Towards the bottom right here is our cancer center, and the first SLP joined the ENT department here in the late 1980s, early 1990s to help build and staff the laryngology and head and neck patients that were being seen by our ENT physicians, mostly on an outpatient basis. And on the top of the photo right here, when I first joined, this was a private hospital not associated with the University of Miami. About 6 months after I joined University of Miami, the UM purchased that private hospital, and that's when we were told that we have 2.5 years to prepare to provide acute care services across the street. So while we were preparing for this, we had 3 different asks and dreams. The first one was a hard ask, and that's we wanted to be able to record our MBS studies. Okay, they were not being recorded by the previous group. I wanted to improve post-op communication and pulmonary hygiene for patients undergoing total laryngectomy. And then the last one was to obtain a FEES card to expand instrumental swallowing assessment options for inpatients. So our first ask, and this was a hard ask, is to record our MBS studies. We met with one of the radiologists at we call it the tower now, and we were asking him, well, why don't you record modified barium swallow studies? And he said, well, we have a written report. And that written report mostly only spoke about penetration and aspiration, kind of the typical note that we would see from a radiologist. But we went above that and we said, well, how do you provide a copy to a patient? Not all patients are going to be staying, in the institution. What if they're traveling and they're going to go somewhere else? I think it's important that they have a copy. And then we went further. How do you compare multiple studies? When a patient is doing pre and post exams. And what about the other parameters that are important for swallowing? It's not just about aspiration and penetration. We need to know why a patient aspirated, and that's why it's important to get a unit that will record it. So we got one of those from K Pentax. We actually received this the very same week we were going to start providing acute care services. Our debut there was September of 2010. Our second ask or dream was to provide post-op communication and pulmonary hygiene to patients undergoing total laryngectomy. If you guys have heard this talk before, I'm just going to provide a quick synopsis, but a specific reason why I'm saying this. So, with this, patients would come into the hospital with the ability to speak. Yes, they have laryngeal cancer and they need a total laryngectomy. But the fact that they would be leaving the hospital without a reliable method to communicate afterwards, to me, it was quite cruel, to do that. When patients come in and they have to leave with a wheelchair or crutches, the university, the hospital will provide that. So why can't you do the same in these cases? And then we went and we spoke with key stakeholders about what happens if there's a fire at the patient's house. How will they call for help? What if their significant other or family member has a medical emergency at the house? How are they going to be able to communicate to call for help? So we were able to eventually uh, receive this a kit where the patient can leave with an electrolarynx and also with a HME. This was finalized in 2021. This was my second project, first one when I was deputy chief of our division. And the reason that I'm saying this today as part of this talk is because this is where I learned how to work with sales reps and clinical specialists from industry who were able to provide much of the administrative behind the scenes efforts with the administrators from my institution that I never knew or knew where their offices were or what their roles were. And I probably didn't even want to know where they worked, but I could not do something like this with my clinical demands. So my advice, if you're working with sales rep and vendors, try to find a project that you can have a mutual benefit. Okay, they should not tell you why you need a product if you don't believe in it, and vice versa. If the sales rep or vendor does not help you, you can also ask to work with someone else or consider a competitor's project. But this was key in terms of teaching me how to go through all of the steps to make sure that I can advocate for patients and improve the services um, that we provide as SLPs. All right. Number three is obtain a fees card. So as our services started to grow, I think we started with maybe an average of 8 to 12 consults a day. Then we were creeping towards 15 to 18 consults a day, and then getting closer to 20. Um, just like most institutions, IR took our second floor room, so now we only had one. So now we had a whole line of patients, not just patients that need modified barium swallow studies that there's a wait time, but other studies that need to be done in the fluoroscopy room, we're occupying space so that we can do these studies. So in several instances, we were not able to do a modified barium swallow study on the same day. And you guys know if that doesn't happen on the same day, this may increase the length of stay of the patient, and patients can be on unnecessary modified diets or even on an NPO status. And of course, we know that not every patient can be transported to radiology due to reliance on heavy, bulky ICU equipment, having multiple lines, and factors related to the patient's weight. So we were making our case over the years to see if we can get a fees cart. We would speak with ENT and hospital administrative leadership, and we kept receiving no as the answer. Okay. And you would think that working at an ivory tower, such as most academic centers, are that they would be able to have endless resources, equipment, and supplies, but that's not the case. Okay. We are competing with every other specialty area within our hospital and healthcare system, and everyone wants the latest equipment and devices, so I get it. But despite that, all of these no's, we were collecting data. Okay. We were saving every email that radiology said that an MBS could not be done on the same day. We were relaying this information to the referring providers who wanted these MBS studies, and we encouraged them to call radiology themselves to blow up to get the study done. Okay. And these referring providers eventually became our physician champion so they can advocate for us. It's nice when it's not just the SLP who wants to advocate for better services. We have our physicians with us as well. Okay. And then we were also creating a list of patients who would potentially benefit from from a fees versus just doing a clinical swallow exam. Okay. We all know the benefits of being able to see versus take a guess. Okay. And then seeing which one of these CSE consults ended up being NPO or PO. Well, in 2020, we upgraded and we got the TIMS MBS units. We got three of them, okay, and these were to be part of the proactive multi-institutional randomized clinical trial. And we got an idea here because when we upgraded to the system, okay, and this was during the times of COVID, we had our DSW, our Pentax DSW cards. We had three of them, okay, so we said, wait a minute. We have one here. This one is outside our fluoro suite at the cancer center. This one, and it even has the old K Pentax swallowing signals lab. For those of you who have been SLPs as long as I have or longer will know what this is. Okay, but we gutted it. Okay, and we said we can turn this into a fees cart. Okay, so um, we actually had one of the Pentax reps was in town and was doing their friendly visits to check up on us. And we said, actually, we have a task for you, if you can help with these cables. So here we have, if you see these fuzzy pipe cleaners, this was when we were doing this before the rep was in there, just so we know which cable was going where. Okay, so as most SLPs, we have different other tasks involved. So IT, biomed, um, you can add that to our resume. And then at the end here was one of the prototypes of how the fees cart was. And we actually had a light source from the ENT towers when they upgraded their systems. So we connected that with the DSW right here. And we were playing around. Where do we put the keyboard? Where do we put the tray that has the scopes? So here we are. We're playing around with that in the office. Part of this process, it needs to be moved. Okay, so this is our office space where the unit is coming from, going through the hallway down the elevators. And here in the middle, you can see myself with my prior boss, who's an amazing SLP, uh, fortunate to have such an excellent mentor, and hopefully you have an excellent mentor that gives you the confidence to always persevere. And if there's no, you find a way to say yes. But here you can see where the cancer center is, and then all the way in the back, that's the our acute care hospital. So we have to get the unit over there. So um, my point with this photo here is that uh, we were going back and forth between the hospital and ENT as to who's going to pay to move the cart to the hospital, and we got fed up one day and we said we're going to move it ourselves. Okay, and as most of these units, or those of you who have had these units, it's a two-person team, and here we are going through the courtyard to move the device. Here we are going through our cancer center. This is the big crosswalk that connects the cancer center to the hospital. And of course, we're having fun with this, so here we are striking a pose when we're doing this. And then of course, here's a video going through the main street.
Not even 8 a.m. The speech team is pushing a cake fast across 14.
You can see things moving around.
Friday morning shenanigans.
Okay, that was our colleague Amanda, who loves to take videos of us. And then we finally brought the cart, to one of these storage rooms in the ICU. Here we had changed the keyboard, so we were able to successfully obtain a fees card, but now we needed dedicated scopes. So now we got to find funds for this. So we wanted to get two scopes so that while one is being used or processed, we have another one. And there are costs with that. And then sometimes there's hidden costs. There was a leakage tester, okay, that we didn't know about, $298. And this hidden cost delayed the start of our program by 6 to 8 months. Okay, um, so now I have to tell the hospital leadership why we need to get those scopes. So here's where all the references, and I think Tim's University has webinars, and there's other webinars out there that talks about how to um, pay for a unit versus, and that includes direct cost savings and indirect cost savings. So we went over that with our hospital leadership. Again, this is mostly related to getting the scopes. One of the things that I did is I tried to create a clever slogan, with them. So I call it the 1-to-1 special. So if we can prevent one hospital-acquired aspiration pneumonia, reduce length of stay by 2 days, and prevent one hospital readmission due to dysphagia, we can pay for the cost of both scopes, the leakage tester, and all the other non-related items that speech has in their budget. You're welcome, voice team. It doesn't really happen like that, but just to drive the point as to how much, how fast an institution, I should say, is able to recoup the costs of a system like this. And then we had our central sterile processing team. They created these cases for us, specially made, okay, that held the scopes because they were going to be transported from floor to floor. So it was important that it's not moving around too much. So, and this was at no cost. And, so that was nice. And then, so our unit here on the left here, we knew that it was not going to last that long. I think it was on Windows XP. It was on its last leg, but we got 1 year out of this that until it was declared obsolete by the biomed team. But we were able to use the device to prove, okay, to the healthcare leadership and the administrators at the acute care hospital that we can do this, that we can uh, take patients off feeding tubes. We can decrease costs related to having unnecessary modified diets, improve quality of life, reduce hospital life of stay. So we were able to time it with our next fiscal year budget And then we actually were able to get a TIMS unit. We decided, the Pentax scopes were very good, brand new, two of them, only about a year old. So we had it, so we have the TIMS system embedded with the Pentax scopes. Now, after we have this unit, after several, now over a year of using this device, we started to notice that it was quite a burden having to move this device. Our hospital, acute care hospital, has 9 floors. We're storing it in the ICU unit on the fifth floor, and then our scopes are kept on the third floor. So it would take nearly an hour to complete this, with two people moving the cart. You remember this photo right here of myself and Dr. Lundy moving these cards. So we had an idea. We were thinking about, wait a minute, ENT just started using the AMBU single-use scopes for their inpatients. And I've heard some SLPs that are using this. The advantage is that our university already has a contract with AMBU. So all we need is to order a monitor, and it wasn't that expensive. The scopes are already there. These are lightweight, they're portable. This should be very nice to move from floor to floor. So we spoke with our SLP team about this and we tried it and we liked it. And we said, boom, yes, this is exactly what we should get. And there is how we got our inpatient hybrid fees program. So starting with, having more of the heavier system, but has the use of high quality scopes, better light system. Decided to keep that on the ICU floors. So again, that's on the fifth floor for us, 4 ICUs. We don't have to take elevators. And then we have the AMBU scopes for all of the other 8 floors. So it's not what we originally wanted. It's how it happened organically, and it's been working fantastic with us. So, with that being said, I'm going to pass it to Ronja, who was our clinical fellow at the time of this project. She had expressed interest in fees and doing lymphedema. And I said, well, we're just about to start our fees program and you're going to lead this. So she's going to take over for the second half of this presentation.
Perfect. Thank you, Mario. Thank you for such a lovely story time, showing the behind the scenes of what really goes on. Okay, can everyone see my screen okay? And can hear me okay? Hope so. All right. So as Mario mentioned, my name is Ronja Hildebrand. I am a speech pathologist at UM with a specialty in head and neck cancer and also a certified lymphedema therapist. I did my clinical fellowship here at UM and have been here ever since. Unfortunately, they couldn't get rid of me, so they're stuck with me. Um, okay, so we've had all this talk about hybrid fees program, but what actually is a hybrid fees program? So it is when a facility has both access to the reusable and the single-use scopes. So this helps optimize flexibility, it helps cost efficiency, and clinical reach. So the rationale for using a hybrid program is the variability in clinical environments, such as the ICU patients, floor patients, and even outpatient clinics. The different needs regarding like infection control, scope availability, and turnaround time for disinfection. So what does a hybrid fees program look like? So we're going to use the example at so a large inpatient academic medical center, right? So we have 2 reusable Pentax scopes. We have about 10 to 20 ambu scopes, and we have dedicated fees carts. So we have a fees cart that is stored in the ICU, which is our Pentax fees cart. And luckily for us, all of the ICU floors are on the same floor. So it's very easy for us to, as you saw that huge cart, it's easier, I should say, not easy, for us to transport it from one ICU to the next, and we get to avoid the elevators. So no elevators, no time. That significantly helps in reducing, the wait and for the patient waiting to get the fees done. And then we have a floor cart, which we house within the ENT floor. So the ENT floor is on the 7th floor. And as Mario was saying, we have many floors at UM. So it's very small and we're able to transport it very easily. We're able to use the regular elevators instead of the ones that we would have to with that ancient huge cart. And this saves us a lot of time. The ambu takes probably about 30 minutes for us to grab the scopes, grab the monitor, and go do the fees. Whereas the Pentax, when we had to use it across the entire hospital, would sometimes take up to an hour and a half. Getting the scopes, completing the study, having to return it, versus just tossing them out, right? So this saves a lot of time, and especially on those busy days, it can be a lifesaver. So yeah, this is just an example. This may look different depending on what kind of setting you guys are in. So a community hospital, for example, it might look similar, just on a smaller scale. Okay, so let's take a look at the equipment comparison. So we have two pictures here. The top is the Pentax scope, and then the bottom is the Ambu scope. So we have the reusable scope at the top and then the single-use scope at the bottom. So pretty much the Pentax in general has high image resolution and has better durability, of course, since we have to keep using the same one for years, hopefully. And it has a very sturdy design. And some models have better lighting. So as you can imagine, this can be crucial for those critically ill patients, especially in the ICUs, which is why we typically use the more heavy set one in our ICUs floors. Then we go on to the Ambu single-use scopes. So the Ambu is slightly reduced in optics, but it's still clinically adequate. And it has significantly improved over the years. So they're actually, I believe, coming out with a new one soon. We kind of got to see a little preview of it, and the imaging looks a lot better than the one that we have currently, which, is very promising. So these scopes, I assume, are probably going to continue to get better and better over time. And of course, the Ambu is a lot lighter and more flexible when using. So fun fact, the Ambu scopes are actually made out of bioplastic material. So they're made by byproducts of waste. So they gave us an example of cooking oil, which we thought was pretty interesting. I don't know how they do it, but I thought it was a fun fact to share. Okay, so here we have a couple of images. So on the left, we have the Ambu scopes, and then on the right, we have the Pentax scope. So in all of these cases, we gave thin and a puree. And this is actually the same person. This is our current clinical fellow who was so kind to offer her nose and got scoped twice that day. So same day, same position, we just used a different scope. So off the bat, if you take a look at these images, I think most of us are already going to be able to tell that on the left is a little bit darker than on the right. The lighting is, I think, the primary thing that you can see right now. So I'm just going to play part of it just so that way you guys can see the differences. So again, this is the Ambu scope, and she swallowed. We told her to fake a dysphagia, so she tried to delay her swallow a little bit and have some retention. Did pretty good, I think. But there is that thin liquid. And then on the right, we'll play the thin with the Pentax. She did say that she felt a little bit more phlegmy that day, so the scope in the beginning was a little bit fogged, I will say. But as you can see, the contrast and the differences are pretty clear. Okay, so now moving on to the puree. And I apologize if these are a little bit small. I hope you can see. There's that delayed swallow. And then here we have the Pentax. see if I can make it a little bit big. Okay. All right. So we'll go ahead and move on. So I hope you guys were able to see some of those differences in the quality, but still able to get some great information. Okay, so cost consideration. So I know Mario already touched on this, so I'm just going to go over it briefly. But pretty much the Pentax has a high initial investment, so around $10,000 to $15,000 per scope, and it requires ongoing maintenance and reprocessing cost. So those hidden fees that Mario was talking about are, also contributing to that. And then the Ambu monitor is a lot cheaper, so it is around $2,000. And we do have the scopes that we have to buy, which are around $150 to $300 per scope. So no maintenance, but cumulative cost increases with volume. So this is definitely something to consider in a high caseload clinic, having to buy multiple scopes depending on how many people you see. Okay, so training and competency considerations. So for the Pentax, I would say that it does require a little bit more training. It's a little bit thicker and heavier and not as forgiving, especially, with those clinical fellows that are just starting. They don't have, the perfect posture or the right placement just yet. So it may be a little bit more uncomfortable for the patient. And then the ambuscopes are, I would say, a little bit more intuitive, a little bit more lightweight and slightly smaller, so it makes it a little bit easier to use. So we kind of have a standard training for both scopes. So pretty much we want to supervise the passes on colleagues or other staff, such as nursing, anyone that's willing to offer their nose during downtime in the clinic. We like to have that as practice time and utilize that time wisely. And we also have in-services. So the representative from the companies will come and join our meetings, and they'll provide like a little refresher, any new updates that they may have. And sometimes they provide the training and bring some extra scopes so that way we can take a look and practice together. So again, this becomes very, very helpful when we have new hires, clinical fellows, so that way they can become more comfortable and have a proper training, which is kind of included in there. And also the reps can be very helpful when it comes to integration of new systems. So definitely take advantage of them. They have lots of knowledge and this is what they do all day. So don't be shy. So our documentation also includes which kind of scope we use. That is part of the competency, but then also we always have research in mind. So if we want to go back and take a look at, the differences between the two scopes, we have that available to us, that information. And I'm not going to go too far into detail about this. I know Tim's University has great webinars, so browse their website and I'm sure you're going to be able to find a lot of information. Okay, so moving on to advocacy and administrative considerations. All right, so building a case for a hybrid fees program. So a hybrid fees program improves flexibility, it maintains continuity of care to the patients, it reduces delays from scope issues, and supports infection control while allowing coverage across multiple units. So we need to work with infection control, finance, and medical leadership to support safety, rate of investment, and workflow. So this is definitely not my specialty area, as Mario was more so the mastermind behind all of this and putting the administrative work together. But from a clinical perspective, I can say that, all of us were helping in tracking everything. So we helped track the emails that stated delays in instrumentation. We made sure that we kept track of the consults and number of completed fees. We did a whole list of holds due to unavailable imaging, discharge delays. There's so many things that go into delaying instrumentation. So all of this combined over, I would say, months and months. I don't know if it was close to a year. It felt close to a year because everything we kept track of. it helped us at the end to support the additional, fees, the AMBU fees to have that join our hybrid program. So all of that information was very valuable. And if you have any questions at the end, maybe Mario can go a little bit more into detail regarding this, but keeping track of everything. All right, so let's talk about some clinical scenarios. So when to use which scope, right? So you have both. How do you go about choosing one? So Pentax, again, like I've mentioned before, high volume clinics where cost per use is low. It's great in stable patient environments with reliable reprocessing. And of course, when imaging quality is critical. So if you're expecting someone to have silent aspiration, and especially, in that ICU population, Pentax may be a little bit better at it. And then we have AMBU. So if you need to travel, from floor to floor, for example, or the patient has isolation precautions, or if there just isn't a reusable scope available, you have that. So, sometimes there are delays, unfortunately, but that doesn't stop us with the hybrid program, right? So we don't have access to the AMBU, the Pantech scope. We're going with the AMBU. It's not going to stop us. All right, so this is our decision-making framework. So we take a look and take a couple of things into considerations. So we have the patient's status, right? So we want to take a look at infection risk and the patient's mobility, taking a look at the patient as a whole before we make a decision. We don't just say, oh, this patient is on the ICU, we're using this type of scope. No, we, of course, like any other instrumentation should start with a clinical bedside evaluation first, where we can see the whole picture. Because sometimes when we do that chart, the patient is not what it actually seems. So, and especially in acute care, I mean, it can change from 1 hour to the next. So definitely taking the patient as a whole into consideration when deciding what to go with. Next, the location of the exam, is a factor, right? So like I mentioned before, we typically use our Pentax scope on the ICU floors, and then we have our AMBU on the other floors. Scope availability, and then scope turnaround time. So, on those super busy days where we have multiple fees, right? Is it going to be cleaned in time for us to do the third or the fourth, right? Some days are chaotic, so we need to be prepared. And then, of course, the need for documentation and video. So as you can imagine, having that huge fees cart that the Pentax has, standing somewhere in the hallway and trying to review images, that can be a little bit complicated versus having a little dainty AMBU tower that won't really bother anyone. It's a lot easier to kind of take that time to review again. And sometimes you can even, while you're documenting, continue to look at those images as needed before having to put everything up. Okay, so let's talk a little bit more about the ICU population. So when we're thinking of the ICU population, that typically means they're critically ill patients. They have a weak or at least a weaker cough than most others. They have reduced sensation and typically are at higher risk for developing aspiration pneumonia, having silent aspiration. So, we have to really, really treat them with care, right? We care for everyone, but they're fragile. So why might we use a reusable scope, right? So that will provide superior visualization. It can provide better secretion contrast and more precise documentation. But why might we want to use a disposable one, even if they are in the ICU? Maybe isolation precautions, immediate availability, or avoiding those transport delays that we were talking about, right? So each case requires decision making. Has there been an instance where the Pentax cart was down and we needed to use an AMBU scope in the ICU? Of course. Has there been a super complex case on the floor that required advanced imaging And we just had to move that huge old Pentax tower to the penthouse. Also, yes. So flexibility is key. Decision making is not black or white. We need to take everything into consideration before deciding which scope to go with. Okay, so now we're going to go into some case studies. So let's go ahead and put the practice into some case studies and apply it. So we have a 72-year-old gentleman. Pertinent medical history is significant for esophageal cancer, and he is status post esophagectomy with gastric pull-up. He also has a history of hypopharyngeal cancer, and that was treated with chemo and radiation, which the patient completed in July of 2022. And with all of that, he also had a left-sided vocal fold paresis. Okay, so he presented to March 2026 with a 4-day history of worsening productive cough, a fever, and shortness of breath. He developed hypoxic respiratory failure, and his chest CT was concerning for aspiration pneumonia. So with that information, what do you think? Which scope would you choose and why? So feel free to write your answers into the chat and we'll keep an eye out on them. Okay, so I'm seeing a lot of Pentax. Good. All right. Yes. So, let's see. Are you guys able to see that screen? Let's see. There we go. Move you guys out of the way. Okay, perfect. So most of you said Pentax, and that would be correct. So this case, we went with the Pentax scope as well. All right, so here we have some clips of the fees. They're just very short. I just want you guys to be able to see the imaging. So let's go ahead and play that. So the initial view right here. So as you can see, we can see some of those secretions. So that is what it looked like before we gave anything. Okay. Let's go to the second one. So this is with thin liquid. So green is the thin liquid, and then blue is the puree. Okay, you can really see the difference from what it looked like during the initial view to now after the thin liquids. Lots of residual. Kind of fogging up that camera. Reduced pharyngeal contraction, not really, cleaning that camera off for us. But that is what it looked like with the thin liquids. And then here we have the pureed consistencies. He's working on it, working on it. There it goes. Green turns into blue. All right, so we can really see the difference. We can see the difference in color very clearly. And let's move on to the next slide because, drum roll, silent aspiration. So the patient had silent aspiration, and I hope you guys can see it as clearly as I can on my screen, but that is very much so aspiration, right? So we're able to see it very clearly. We don't have to question it. And again, the patient didn't even respond to this. So we were able to detect that and help him out. All right, so our next patient is an 80-year-old gentleman. Okay, he has a pertinent medical history that is significant for left tonsillar squamous cell carcinoma. He's status post torse radical tonsillectomy with advanced pharyngoplasty and left neck dissection. And this patient primarily was complaining of pain. He was complaining of globus sensation, and he was very anxious to initiate an oral diet. Okay, so these are all very typical symptoms we expect somebody to experience post-operatively, especially after a TORS. We have lots of those. But given his overall image and how everything played out for him, we ultimately decided, okay, let's take a look and see, is it pain related or is it actually a dysphagia, right? So of course, as we all know, there's no way of determining that unless we can actually see it. So we decided to proceed with imaging with him. So for this patient, which scope do you guys choose and why? Seeing one answer. Give some time for more. Yeah, so let's see what we decided to go with. All right, so here we have the AMBU. Okay, so we have again some FEES clips here. And again, these were used to take a look through AMBU. So if you have that other picture in mind of that horrible silent aspiration and the clarity of that, now compare it to this, right? So we're still getting some great information. We can see here the patient is having some pharyngeal retention. There is some pooling of the liquid within that inner arytenoid space. So we can clearly see what we need to see it, and it's giving us the information that we needed, especially for this specific case. And here's the pureed consistency. Okay. So with doing this quick FEES, we were able to rule out aspiration. We were able to make the least restrictive diet recommendations with actually knowing exactly what's going on because we were able to visualize it. And most importantly, we were able to ease the patient's mind. He was able to trust us, and it helped increase his PO intake, which ultimately reduced the length of stay in the hospital, right? So we were able to do all of that with just a 30-minute quick assessment, thanks to AMBU. Okay, so that brings us to the conclusions. So a hybrid FEES program optimizes the flexibility, efficiency, and patient care. So with the Pentax, it's best for high volume controlled settings and when superior imaging is required, right? Then we have the AMBU, which improves availability, workflow, and it reduces delays. So I want to highlight that they are not meant to compete with each other, but rather complement each other, okay? They're working as a team. And evidence shows comparable clinic performance. So you want to choose based on the clinical question that you have regarding that specific case, right? So successful implementation requires a team. It requires structured training, stakeholder collaboration, and funding models. So there's a lot that goes into this.
Yeah, perfect. And it's also important to take advantage of the resources that your institution has. So are there vendor contracts already there that you can at least start it? And even if they're not with ENT or speech, there could be a certain vendor that is with another specialty, so the fact that their contract is there can just help speed up the process. Again, just so you can start and get data and show the healthcare providers and administrators that this can be done. Um, You can collect institution-specific data, okay, to provide justification, whether you're in the process of doing this. A lot of the articles will provide examples as how to do it, but when it's institution specific, that's where the key is. Like you heard Rania say, this is our program at University of Miami, our hybrid program, but another academic center, their hybrid program may be completely different. Okay, so make it specific for the institution and the questions that you typically are going to get in your consults. Find a physician champion. That was so key for us because the physicians, they listen to them more than speech, but they really back us up. I'm so thankful for them. I'm so thankful that our division is within ENT because we've got 10 head and neck surgeons and 10 head and neck surgeons that will go to the floor of the office of the CEO and make sure that they find the $25,000 that we need in order to implement this and then be persistent. You saw this took years for us to be able to do this, and we strategized, how we can do this. Again, coming with nothing, refurbishing a cart just again to prove that we can do it. And I love, Rania made the point that these systems are here not to compete each other. They are here to complement each other. So, yes, we want to answer the question. And sometimes, if we know a patient is in pain, okay, then the disposable one may be the easiest because it's not going to be in the way, or the patient's comfort, I should say, um, will be respected, while still answering the question that we have. Um, Let's see. Another thing I want to say, so we're talking about Pentax and Ambu. There's a bunch of other companies that are out there. You heard us talk about the cons of the scope, but again, we look at what complements it with the pro. So we are able to become and have a better decision when we see these patients. One of my other specialties is TEP management. Okay, in our hospitals, we have products from InHealth, we have products from Atos. So the fact that we got both gives us more options for the patient. So at the end, I actually love that we've got a hybrid system because when one system is down, we can go to the other scope. So we're always moving and we can do this 24/7. Rania, you want to go to the next slide? Yeah, questions and show some of the photos that have you saw the photos of myself and my other SLP colleague moving the cart. This is Rania on the day that we were moving the Ambu cart across the street, and she's doing it by herself. Okay, she's able to do this easily. And then this is when three of us were in the disinfection central processing unit to take a tour and be very humble so that they can get us the case for free. There were questions about archiving and sending images up to the electronic medical records. Yes, a lot of there are capabilities of doing this. So you can speak with your sales rep for whatever vendor, and they'll be able to help integrate that with you. We are just about to finish the process of uploading videos to the to our electronic medical records. We use Epic, and it would be for both the TIMS system. Okay, so the TIMS system is the one that has the Pentax scope, and then the Ambu system as well, so that we'll have reports and images available in the electronic medical records.
Let's see, there was a question about, do you find that you use different contrast agents for the different types of scopes? I think we typically try to follow the same protocol. However, there are instances where we'll use different colors as well. So sometimes we even use like the white contrast, but primarily, we have the green, the blue. So it really depends from patient to patient and what we're seeing, but we do have it available during each study in case we need it.
Yeah, perfect. And thank you, Brooke, for answering that question about Ambu being connected with Tim's. Yep.
Yeah, I just wanted to mention that because we've had a lot of questions about integration from a variety of scopes to
Yep.
PACS. So definitely when you're starting a program, make sure you talk to your PACS administrator to see what files they accept. If you're going to be sending from Ambu to PACS, you want to make sure that they allow for MP4. If they do not allow, if your PACS does not allow for MP4, you'll need some other option. So
Yep.
Tim's, it again, I work for Tim's, but I do have Tim's with my Olympus system at work. Tim's can be added to any scope to make this happen, to make that integration with PACS or VNA or your EMR. So I know there's another question about integration into reports. So you don't have to use Tim's, but just know that it can be a super easy thing. Like we can install it that day and then that problem is taken care of.
Yeah, a lot of times when we get a new system, there is a phone call that has the SLPs, the clinic managers, IT biomed, and they can help with those um, that great advice that Brooke gave. Yeah, all the processes, the behind the scenes processes with uploading to PACS or the medical records. Yep. Yeah, pediatric fees. Yep. Smaller side on the disposable option. Yeah, that's great.
Uh, there's a,
Um,
there was a question in there about whether your team uses the Tim's software on Ambu for reviewing, or if you're using the Ambu software for reviewing.
yeah,
Sorry,
we
it was in
have.
the chat. Not
Yep. We have the Ambu system that has a different software right now. What our, so our hybrid system could it continue to evolve, and maybe doing a Ambu scope with Tim's may be an option in the future. Yep. But right now, since we got the monitor, yeah, we have it. Ambu has its own system. Yep.
Awesome. I know we're approaching the top of the hour, so quick housekeeping items, and I did put this in the chat, but just repeating myself for those who might have missed it. This webinar was eligible or is eligible for zero point 0.1 ASHA CEUs, so just complete the brief survey that's in the chat, and it'll be sent out via email from Zoom over the next couple of days. And then if you'd like a certificate of completion, please send us an email at tims-unum@tims.com, and again, that'll be sent out via email. While we're wrapping up, I actually had a question for you both about just budgeting for ambu scopes because I actually don't know the answer to this question. So I'm curious when you're looking at your budget, how I know you give a price range, but is there a set price per scope or does it decrease in cost? Like if you're ordering more or what does that look like?
Yeah, I think I'm not 100% sure, but you know, the fact that we are under ENT, the ENT, the ENT budget is paying for the scopes for us. So we are very lucky, and we know that because of that. I think that is the ivory tower um, advantage. That definitely is one. But yes, we buy them in bulk, so. But I don't know if there is a discount if there is a bulk package. I will ask and inquire. Yep. I will help the ENT side with that question.
Thanks. Yeah, a different practice I was at, we were in otolaryngology and we had access to 20 Olympus scopes and I felt pretty special
Yeah, right.
having that access to that. Um, one of the attendees said, is the disposable scope billable to a patient?
Yep. So when we do the fees, we go into the ENT corner and kind of like nursing does with any sort of supplies. We go in there, we just scan one of the scopes, and it gets directly connected to that patient that we're going to use. And we can do it, across the entire hospital, so it doesn't matter that were on the ENT floor. We're able to bill it to that patient and then go straight for the fees.
Yeah. Yeah, perfect. And Molly's talking about a cost comparison in the past. Yeah, this will be dependent on your institution. Yeah,
Mhm.
absolutely. So track, this again, we're providing our experience at our hospital, so do it at your hospital, and your system may be completely different than ours. But at the end, we actually love it because we've got different options available. We can do the quick scope, with the patient, or we can do a more extensive one if we need higher resolution. Yep. Yeah, so don't follow what we do. You you use this as inspiration to examine your institution and see what works best for you. Okay, and definitely, take advantage of the clinical specialist and sales reps so that they can guide you with the questions. Absolutely. Thank you, Molly, for saying that.
Yeah, I will mention to help with some of these questions, we developed a fees program page on our website that I can add to the emails. It again, we just want people to be successful at Tim's. You don't have to get Tim's, but key questions that were addressed in this webinar, you want to make sure 100% that your fees are recorded and can be
Yes.
archived, and you want those images. And I think sometimes on the speech side, we forget to ask those IT questions because we're thinking about, the clinical side. So I'm happy to send that link out too to anyone who's looking to develop a program or a hybrid program so that you have, you can come into the meeting armed with all the right questions to ask for your institution.
Yeah, and I think can make another plug, Brooke, about some of the other Tim's University courses on fees, right? Because there were questions
Yeah.
about competencies, and training. So I believe there is one. So definitely take a look at that.
Yes, yeah, we have if you go to our on-demand Tim's University page and click on fees, there's a whole section. So we have some more introductory courses and then some advanced courses
Yeah.
that go through, case analysis, reporting, etc. And then, if you have questions about wanting access to fees training, just send us an email. We're happy to connect you with different people. We don't offer like in-person training ourselves, but we're happy to connect you with people in the field that do offer that. Awesome. Well, with that, I just want to thank you both for offering your time, your expertise. I loved seeing the photos of your team. Like I had shared with you in our prep, I've been there pushing a cart across the street. So definitely relatable and just really cool to see how you guys advocated for advancing your ability to offer fees to patients. And I want to thank everybody for joining us this evening for this session. This webinar was recorded, so it'll be up on the TIMS website within 48 hours. And if you have questions, feel free to send us an email. With that, we will sign off. Thanks, everybody. Have a great night.
Yes. Thank you. Good night.
Bye.